since most of you are late, we're just going to post the video recording. Okay, so like we agreed, we'll be looking at anti-malarial drugs today as a continuation of our lectures. Okay, so look at the introduction by looking at malaria in general. Okay, so we'll briefly discuss what malaria is. Malaria is an important parasitic disease of humans and causes hundreds of millions of illnesses per year. Okay? Most common causative organisms of malaria are the falciparum, the vivax, the Plasmodium ovale, Plasmodium knowlesi, and the Plasmodium malariae. Okay, but Plasmodium falciparum is responsible for the majority of the serious complications and deaths. Okay, now when we are looking at anti-malarial medications, these are drugs that are designed to prevent or cure malaria. The anti-malarials may be used for some of the following. Okay, we can use them for treatment of malaria in individuals with suspected or confirmed infection. We can use anti-malarials for prevention of infection in individuals visiting a malaria endemic region or who have no immunity. Okay, malaria chemoprophylaxis. Then we can also use them as routine intermittent treatment of certain groups in endemic regions. Now, for us to have a better understanding of how these drugs will be working, we need to look at the life cycle of the parasite, okay, the Plasmodium life cycle. Okay, the cycle starts with the feeding of the Anopheles mosquito. Okay, so as a mosquito comes in for feeding on a human, which is the host, in its salivary glands, with it carries sporozoites. Okay, so as it starts feeding, it deposits sporozoites into the blood circulation of a human being, and this is where the exoerythrocytic stage starts. So sporozoites are introduced into the host. Now, these sporozoites will move in the bloodstream, and then they will be deposited into the hepatic circulation, where they are going to infect the hepatocytes there. Now, for exceptions like infection with Plasmodium vivax and Plasmodium ovale, these sporozoites are going to mature into hypnozoites, and these ones can remain dormant in the circulation for months and for years. But for these other species, the sporozoites are going to infect the hepatocytes within a few days. And then when they enter the hepatocytes, they're going to mature into what we call schizons, okay? So the hepatic schizons. Now, when these hepatic schizons mature, they're going to rupture the hepatocytes, releasing merozoites. These merozoites are going to be released back into the bloodstream, okay? And then this is where the erythrocytic stage of the cycle starts. The merozoites are going to target the red blood cells. Okay, so the merozoites are going to infect the red blood cells, and then they're going to mature into early trophozoites. Okay, and
so I'm not getting you.
Rachel, you're not getting me?
Yes.
But you are responding. Is it because I'm too fast, or you can't get my voice?
But the voice.
Okay, so far what I've been talking about, what have you heard? Rachel?
Sir?
I'm saying, should I start over on the life cycle?
Yes, start over on the life cycle. I haven't heard.
All right. Is this okay? Are you able to get me clearly now?
Yes.
Okay, so I was saying, for us to have a better understanding on how the anti-malarial drugs are going to be working, we need to look at the life cycle of the parasite itself in two details. Okay, so we are saying the first part or the first stage of the life cycle is when the Anopheles mosquito comes in for its meal, okay, for a blood meal on the human host. Now, when the mosquito comes and bites a human, it is going to deposit sporozoites, okay? These sporozoites are found in the salivary glands of the mosquito, the Anopheles mosquito, okay? When these sporozoites are introduced into the bloodstream, we are saying the exoerythrocytic stage starts, okay? So the sporozoites are going to move in the bloodstream and they are going to be delivered into the hepatic circulation, okay? And these sporozoites are going to be infecting the hepatocytes there. Now, with infection with Plasmodium ovale and Plasmodium vivax, the sporozoites can mature into what we call hypnozoites, and these ones are going to remain dormant in the hepatocytes for months to years. But with these other species, these ones are going to mature within a very short period, and then they are going to develop into what we call hepatic schizons. Now, these hepatic schizons are going to grow within the hepatocyte. Okay? When they mature, they are going to rupture the hepatocyte, releasing merozoites back into the bloodstream. Merozoites are released back into the bloodstream. We are saying this is where the erythrocytic stage starts. Okay? So, like the schizont is a mature form of the sporozoid, and then it's going to rupture to form smaller parasites or smaller gametes known as.
Only three people.
And then these merozoites are the ones that are going to start infecting the red blood cells. The red blood cells. And then we are saying this is why we are calling it the erythrocytic stage, because the red blood cells are involved. Now, when they infect the red blood cells, they're going to develop into what we call early trophozoites. And these ones are ring-like in structure when you look at them through a microscope. Okay? And then here, there is a mini cycle that is going to go on. When the trophozoite keeps on maturing, it is going to turn into a late trophozoite, okay? And then as it continues to mature, it is still going to rupture to release more merozoites. Now, this rupturing of the red blood cells during this stage of the life cycle is what is going to bring about signs and symptoms, common signs and symptoms of malaria, which are the fevers, chills, and rigors, okay? So this cycle can continue on and on. More merozoites are released when the red blood cell is ruptured, and then it is going to infect more red blood cells. But here, another thing again is going to happen. As the merozoites are being released into the bloodstream, some of them are going to move on and develop into gametocytes, okay? Gametocytes. So we are going to have the female and male gametocytes, which goes on to the 5th stage of the cycle. Now, when the next mosquito comes, an uninfected mosquito comes, it is going to come for a blood meal, and it is going to take up these gametocytes. And then it is going to have the portion of the infection of the malaria, okay? The gametocytes are going to move into the mosquito's abdomen, and then they're going to mature there and form sporozoites and move to the salivary glands, and then the life cycle is going to continue when the mosquito goes for another blood meal. Okay, are we together this far?
Yes.
Rachel, are you still there?
Yes.
Are we together?
Yes, sir.
Okay, so we continue. So we are saying most anti-malarial drugs are going to be targeting the erythrocytic stage of the malaria infection, which is the phase of infection which causes the symptomatic illness. Remember, we were saying during the erythrocytic stage, when there is the rupture of the red blood cells releasing the merozoites, this is where we have the common signs and symptoms. So when we administer these anti-malarial drugs, we are going to be targeting this stage of the cycle. Treatment of the acute blood stage infection is necessary for malaria caused by all malaria species. So, as the red blood cells are being ruptured, we know that we are having an effect on the blood levels in the host. So we need to ensure that we are going to cover for the treatment of this as well. Infection due to Plasmodium ovale and Plasmodium vivax requires terminal prophylaxis with a drug active against the hypnozoites. Remember, the hypnozoites can stay in the hepatocytes for months to years. So we need to ensure that we give them prophylaxis so that in a later stage they don't develop malaria. The current practice in treating cases of malaria is based on the concept of combination therapy. Now, these are the advantages of combination therapy. One, there is reduced risk of treatment failure. Then there is reduced risk of developing resistance. And then there's also reduced adverse effects. Okay, so those are some of the advantages of using combination therapy. Prompt parasitological confirmation by microscopy or rapid diagnostic test is recommended in all patients suspected of malaria before treatment is started. Okay, so before you start treatment, we need to ensure that we confirm that our patient is indeed suffering from malaria, or maybe it is just due to some other infection. The treatment is solely based on clinical suspicion, should only be considered when parasitological diagnosis is not accessible. So when you find yourself in a situation where you cannot do parasitological investigations, okay, for example, you cannot do the blood smears, you cannot do the RDTs, you can use your clinical suspicion, meaning you use the signs and symptoms, the common signs and symptoms of malaria to make a diagnosis, and then you start the treatment. Let's look at the classification of the antimalarial agents. Okay, so we have drugs that will be acting on the intrahepatic stages. The intrahepatic stages. So that is the stage where the sporozoites are infecting the hepatocytes. That is what we are calling the intrahepatic stage. So these ones are going to be having an inhibitory effect in the liver stage from initiating the erythrocytic stage. So before the sporozoites can infect the hepatocytes and later on rupture to go and infect the red blood cells, we need a certain drug that is going to inhibit this process. This is what we are trying to talk about here. Okay, so these ones, we call them causal prophylactic drugs. They'll be inhibiting the liver stage from initiating the erythrocytic stage. Examples we can give are tetracycline, primaquine, proguanil, and atovaquone, proguanil, and pyrimethamine. Okay, those are some of the examples that we are going to be giving. Then we also have the hypnozoitocidal. These ones are going to be destroying the exoerythrocytic hypnozoites of the Plasmodium vivax and the Plasmodium ovale after treatment of acute erythrocytic phase to produce radical cure. Again, this stage is that point where we're saying in the Plasmodium vivax and the Plasmodium ovale, the hypnozoites can remain dormant in the hepatocytes even after treatment for months to years. So now if you're going to give these drugs, they're going to ensure that they attack even the hypnozoites that have remained dormant, and then we're going to have what we are calling radical cure. And an example of such a drug is the primaquine. Then we also have another class of drugs which we are calling drugs that act on the erythrocytic stages. Okay, the stage where the merozoites are attacking the red blood cells. These drugs are used for clinical cure. Okay, these ones have a fast action on the erythrocytic stages. So they are going to be preventing that process where the merozoites infect the red blood cells and then rupture those red blood cells, giving us those clinical signs and symptoms. When you give these drugs, this process will be inhibited. Okay. And we are being told that these drugs have a fast action on this erythrocytic stage. And an example we can give of such drugs are artemisinin derivatives and quinolones. Okay. Then we also use these drugs for suppressive therapy. Okay. Slower suppressive action on erythrocytic stages such as antifolates, tetracyclines, and clindamycin. Remember, we are saying in the erythrocytic stage, we are going to have a process where as the red blood cells keep rupturing, the patient will start developing anemia. Okay, so when we give these drugs that will be acting on this stage, they are going to suppress that action, and then we are going to have suppressive therapy being achieved. Then we have the gametocidal drugs. These ones destroy the sexual forms of the parasite in the erythrocyte, preventing transmission to the mosquito. Basically, the last stage in the host. Okay? Remember, we were saying in the erythrocytic stage, some of the merozoites are going to mature into male and female gametocytes. So when you give these gametocidal drugs, they're going to destroy those gametes, meaning when the next mosquito comes for a blood meal, even when it bites this host, it is not going to take these gametes, meaning the life cycle has been cut short. Then we have the sporonticidal drugs. These ones are going to be destroying the sporozoites, okay, which is like the first stage. So just when the mosquito comes in for a blood meal, when you give these sporonticidal drugs, it is going to take care of the sporozoites, meaning they are not going to infect the hepatocytes. Examples we can give here are the primaquine, pyrimethamine, and proguanil. And then we have the chemoprophylaxis. Okay, chemoprophylaxis. So we have causal prophylaxis. These ones are going to be inhibiting the liver stage, like we had already talked about. Then we have the clinical suppressive prophylaxis. These ones are going to inhibit development of merozoites in the erythrocytes. Okay, so those are our classification of our drugs. Now, 5 broad groups based on the mechanism of action. This is another way in which we can classify these drugs. So we have the quinolones, which is the first group, the quinolones. Quinolones inhibit polymerization of heme, which is toxic to the plasmodium. Okay, so inhibit polymerization of heme to hemozoin, which is non-toxic, thus causes the death of the plasmodium. Okay, so as these parasites infect the red blood cells, you know that red blood cells have 2 components. There is the hemoglobin which can further be broken down into hemoglobin. Now, they use the globin as protein, and the heme is used as it is polymerized and changed into hemozoin. Hemozoin is non-toxic to the parasite. Now, when you give quinolones, it is going to inhibit this process where the parasite changes the heme to hemozoin. Heme is toxic to the parasite. So when the quinolone is given, it is going to ensure that the heme has the toxic effect on the parasite, and then there is death to the plasmodium. Second, we have the artemisins. These ones bind heme ion and generate oxygen radicals which damage proteins in the parasite. That is one way in which they have the effect. So remember, we are still saying that the heme is very toxic. It's very toxic to the parasite. So when the artemisins bind to the heme ion, they're going to be generating oxygen radicals, which are also more toxic to the parasite, and they're going to be damaging the protein, specifically the protein of the parasite. Secondly, it is going to be damaging the potassium, the calcium ATPase transporter, which is also an essential part in the parasite's growth. Okay, so when this pump is damaged, the parasite will also die off. Then we have the antifolates. Antifolates inhibit DNA synthesis, okay, meaning the parasite will be unable to replicate. Examples of these ones are pyrimethamine, proguanil, and sulfonamides, as well as dapsone. And then we have atovacone. Atovacone is going to inhibit electron transport chain in the mitochondria. All these are processes that are important in the growth of the parasite within the host. So if all these processes are being inhibited, we are going to have the death of the parasite. And then we have the protein synthesis inhibitors, such as the tetracyclines and clindamycin. Okay, so those are the 5 broad groups based on the mechanism of action. We have protein synthesis inhibitors, atovacone, which inhibits electron transport chain. Antifolates inhibit DNA synthesis. Artemisins have got 2 mechanism of actions. Okay, they bind to iron and generate oxygen radicals, as well as damaging the calcium ATPase pump. And then we have the quinolones, which are going to be inhibiting polymerization of heme to hemozoin. Are we together? Okay, so let's look at the specific anti-malaria drugs that we have. So we'll start with the quinoline derivatives. These ones, examples include chloroquine, amodiaquine, quinine, quinidine, mefloquine, primaquine, piperaquine, naphthalquine, lufentrin, and halofentrin. Okay, so quinolone derivatives, these drugs have an activity against the erythrocytic stage of the infection. Primaquine also kills intrahepatic forms and gametocytes. So this is the primary mechanism of action. It is targeting the erythrocytic stage. The erythrocytic stage, which we've said, is the stage where the merozoites are infecting the red blood cells, maturing into trophozoites, later on rupturing, releasing more merozoites. So now this process is the one that these drugs have an activity against. So they will be inhibiting this stage. The drugs will be acting by accumulating in the parasite food vacuole and forming a complex with heme. Okay? So the parasite will be infected by the drug, for lack of a better word. Okay? And then it will be in the vacuole where it will form. The drug will be targeting the red blood cells as well. There, it is going to form a complex with heme. Remember, we said there is going to be inhibition of polymerization of heme to hemozoin. Heme is very toxic to the parasite. So, when this complex is formed, that polymerization to hemozoin will be inhibited, and then the heme will have the toxic effect on the parasite. Okay, which is basically the last point there. They inhibit heme polymerase activity, resulting in accumulation of cytotoxic free heme, and then heme polymerizes heme. Okay, heme polymerizes heme to non-toxic hemozoin. Now, when they inhibit this enzyme, there will be the cytotoxic free heme, which is going to be having the effect on the parasite. Okay. Then we have the methanoquinolines, okay, such as quinine and quinidine. Quinine is a derivative from the bark of a South American cinchona tree and exists in oral and parenteral forms. Okay, so this is basically where they synthesize this this drug, quinine, from this tree, the cinchona tree. Quinidine is a stereoisomer of quinine, available in parenteral formulation, and is very effective for treatment of severe malaria. Okay, so quinidine is made out of quinine, and it is only available in non-oral routes, which is very effective in very severe malaria. Quinidine is a more active antimalarial, but it is more cardiotoxic, meaning when you give quinidine, you expect that the patient will have side effects in the cardiovascular system. Now, what are the antimalarial effects? So the blood antimalarial effects are that it is blood schizonticide for all human plasmodia species. Okay, so the schizons are the ones that are being targeted by this particular antimalarial, but it is weak against the gametocytes of the Plasmodium vivax and the Plasmodium malariae. Okay, so the schizons are basically the ones that are being killed off. Now, what are the common adverse effects? Synchonism. What do we mean? Okay, tinnitus, which is a constant ringing sound in an ear. I'm sure if you've heard the common side effect of quinine, that most patients that have used it will be like, they'll give you a history of them having a disturbance in the ears. Okay, they'll be hearing a high tone. There will be a high tone hearing impairment, vertigo, nausea, vomiting, abdominal pain, dysphoria, headaches, dizziness, disturbed vision. So these effects typically resolve with cessation of the medication. When you are using quinine and you find that your patient is giving you any of the side effects, the only way you're going to help them is you stopping the quinine. Other adverse effects include hypersensitivity reactions, neurotoxicity, skeletal muscle paralysis, and hypoglycemia. So those are some of the other adverse effects. So you need to be very careful when you're using this drug. Quinine is associated with black water fever in patients sensitized to quinine, okay, which is characterized by intravesicular hemolysis, hemoglobinuria, disseminated intravesicular coagulation, and renal failure. You know that black water fever is one of the common adverse effects or common complications of malaria, but with quinine, black water fever is also associated with it, okay? Black water fever is what I've characterized here. So there will be intravesicular hemolysis, meaning there will be a high rate of destruction of red blood cells. Then hemoglobinuria, disseminated intravesicular coagulation, and renal failure. Quinine and quinidine have a narrow therapeutic window. Overdosage may lead to cardiotoxicity, including arrhythmias and hypotension, respiratory depression, blindness, or deafness. So when you're using this drug, in short, you need to use it for a short period of time, because the more you use it, the more you predispose your patient to these adverse effects, which can be very fatal. When do we use this drug?
So what's arrhythmia?
Sorry?
What is arrhythmia?
Arrhythmia. This is
Yes.
an abnormal heart rhythm. Okay? An abnormal heart rhythm. Are we together?
Yes.
I hope it's...
Yes.
We're talking about the uses. So quinine and quinidine can be used in the treatment of severe acute Plasmodium falciparum malaria. When a patient has any of those 10 complications of severe malaria, you can use quinine to treat them. Quinine can be given via the oral route, intramuscularly, as well as by slow intravenous infusion. For severe disease, quinine is given either intramuscularly or intravenously. Quinidine, on the other hand, is given by slow intravenous infusion. Quinine is safe in infants, children, pregnancy or trimesters, and lactation, so you can use it regardless. Now, what are the contraindications? When are we not going to use quinine? When a patient has developed a hypersensitivity reaction to quinine, quinidine, or mefloquine. When there is a prolonged QT interval on an ECG, which could be an indication of cardiotoxicity, myasthenia gravis, a rare condition in our setting. When there is optic neuritis, glucose 6-phosphate dehydrogenase deficiency. This is also a condition which is congenital. It is characterized by intravascular hemolysis. When there is a history of black water fever in your patient, when there is thrombotic cytopenia purpura, hemolytic uremic syndrome, and thrombocytopenia. So you need to be on the lookout for all these reactions when you are using quinine, and you need to stop when a patient develops any of these. Now, let's also look at a drug called mefloquine, which is structurally similar to quinine. This one is active against all the 4 human malaria pathogens, okay, except the Plasmodium knowlesi. So Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, and Plasmodium ovale. It is blood schizonticide with a long half-life. So again, we're talking about the similarities with quinine. This one is used in the treatment of acute malarial infections and prophylaxis of chloroquine-resistant Plasmodium falciparum malaria. So there is a catch. The difference between mefloquine and quinine is that quinine, we usually use it in patients who have developed severe malaria. But this one, we're going to be using it in patients with acute malaria infections and for prevention against those that have chloroquine resistant Plasmodium falciparum malaria. What are the side effects of this one? Okay, we have nausea, vomiting, diarrhea, abdominal pain, dizziness, neuropsychiatric manifestations such as affective and anxiety disorders, hallucinations, sleep disturbances, nightmares, psychosis, toxic encephalopathy, and convulsions. Those are some of the neuropsychiatric manifestations that a patient can have, as well as bradycardia. So you need to be on the lookout of these adverse effects. Contraindications include seizure disorders, psychiatric disorders, children under 2 years. Unlike quinine, where we can use it in infants, children, mefloquine cannot be used in children under the age of 2 years. It cannot be used in patients with cardiac conduction abnormalities. It cannot be used with concurrent administration with drugs that alter the cardiac conduction, and you cannot use mefloquine in pregnancy. Okay, so that is about methanoquinolones. Okay, do you have any questions before we move to another set of drugs? Any clarifications needed before I move?
Sir,
Yes.
sir, on the slides, I saw something like tetracycline. Is it also used in treatment of malaria? I didn't get the explanation.
It is one of the drugs that are used in the treatment of malaria, but we have not yet come to it. We will look at it shortly as we move on.
All right.
Okay.
Thank you.
Any other questions? Okay, if there are no questions, we move on. So the next set of drugs is the drugs that we are calling the aminoquinolones. Here we have commonly the examples of chloroquine and amodiaquine. Let's start by looking at chloroquine. We'll look at chloroquine first. Chloroquine has an activity against the blood stages of Plasmodium ovale, Plasmodium malariae, and susceptible strains of Plasmodium vivax and Plasmodium falciparum. Okay, when we talk about the blood stages, we are still talking about the erythrocytic stages, okay, where the merozoites are infecting the red blood cells. So, particularly in these species of malaria, we use chloroquine in the treatment of acute malaria for chloroquine-sensitive malaria strains. And these sensitive malaria strains are the Plasmodium ovale, Plasmodium malariae, and some strains of Plasmodium vivax. Okay? It is also used for chemoprophylaxis for susceptible strains of Plasmodium. It is given orally. Parenteral chloroquine is very toxic and can cause very severe hypotension. So always when you're using chloroquine, it is via the oral route, because when you give it through the blood, or if you give it through the intramuscular route, it is very toxic and you can cause severe hypotension, which will be more problems on your part. Now, there's a widespread resistance in most malaria endemic countries that has led to the decline in its use for the treatment of Plasmodium falciparum. Although it remains effective in the treatment of Plasmodium ovale and Plasmodium malariae and in most regions of Plasmodium vivax, which is the reason why we rarely see chloroquine on our tables or in our hospitals here in Zambia, particularly because the most common cause of malaria here is Plasmodium falciparum, and we are being told that chloroquine and falciparum there is a resistance that has been shown to develop. The adverse effects include headaches, dizziness, abdominal discomfort, vomiting, diarrhea, rashes, and pruritus in some patients, neuromyopathy with long-term prophylaxis. So neuromyopathy is usually associated with long-term prophylaxis. Retinopathy is usually associated with prolonged high doses. For example, when you're using it for the treatment of rheumatoid arthritis. And idiosyncratic reactions such as erythema multiforme and bone marrow toxicity, and hemolysis in patients with G6PD deficiency. Okay, so these are some of the adverse effects that we are going to be having with the use of chloroquine. It can also provoke psoriasis, which is another condition, cardiotoxic in high doses and when it is given via any other route except oral route. So these are some of the most common adverse effects of chloroquine. But the important thing to note here is that chloroquine cannot be used in any strand of malaria. It has got specific strands, especially the Plasmodium malariae, Plasmodium ovale, and susceptible strains of Plasmodium vivax. Plasmodium falciparum, not so much, because there has been resistance that has been shown to develop. And its main mechanism of action is that it will be acting on the erythrocytic stage of the life cycle of the parasite. Amodiaquine is a drug that is similar in structure to chloroquine. There is cross-resistance between chloroquine and amodiaquine. Cross-resistance, like we had discussed earlier on, means when you start administering chloroquine and the parasite develops resistance to chloroquine. Cross-resistance means that when you give amodiaquine, there's a high chance that the parasite is also resistant to the amodiaquine. The reason is simple. It is there in the first point, because we are saying the structure of chloroquine and amodiaquine are very similar. So now, although amodiaquine retains some activity against chloroquine-resistant parasites in vitro, cross-resistance is usually the case. Amodiaquine is commonly used in malaria endemic countries to treat chloroquine-resistant infections and is available in co-formulation with artesunate, and it is given orally. So, in order to overcome the cross-resistance, we are going to be formulating the amodiaquine by combining it with artesunate so that we reduce on the cross-resistance, and then we can overcome the resistance that has been developed against chloroquine. And then we're going to be giving this drug orally. Adverse effects include gastrointestinal effects, okay, such as vomiting, nausea, abdominal pain. We can have bradycardia, hepatotoxicity. Okay, those are some of the common adverse effects associated with amodiaquine. Amodiaquine cannot be used for chemoprophylaxis because there is an increased risk of agranulocytosis and hepatotoxicity with repeated doses. Okay, this is why we won't be using it for chemoprophylaxis. Primaquine, an 8-aminoquinoline. This one is active against blood schizons, although it is a slow-acting blood schizonticide. Tissue schizons, hypnozoites of Plasmodium ovale and Plasmodium vivax, sporozoites and gametocytes of Plasmodium falciparum. So it's like this drug is going to be acting against a particular stage in the life cycle, depending on the type of parasite that is infecting this host. Okay, the mechanism of action is that it is going to be inhibiting the heme polymerase, and it is going to be disrupting the mitochondria, blocking the oxidative metabolism, and also it is going to be binding to DNA, interfering with DNA function. Okay, so again, like we have learned from the earlier slides, we have said, heme polymerase is the one that is taking place within the erythrocytic stage. Heme polymerase is responsible for converting heme to hemozoin, which is non-toxic to the parasite. So if it's inhibited, the heme is going to have its toxic effects on the parasite. When the mitochondria is disrupted, there will be oxidative metabolism, meaning there will be free oxygen radicals within the cell, which is toxic again to the parasite. DNA synthesis is also being interfered with the use of primaquine. So it is basically acting on almost all the stages of the life cycle. This drug is largely used to effect radical cure of Plasmodium ovale and Plasmodium vivax. It prevents relapse of Plasmodium ovale, Plasmodium vivax malaria by eliminating the dormant hypnozoites. So it is also going to be eliminating the hypnozoites. It is given in conjunction with chloroquine or artemisinin derivatives in the treatment of Plasmodium ovale and Plasmodium vivax, because these are the two species that it is sensitive against. Okay. When it comes to the other species, this drug is not as useful. So you need to ensure that you have isolated the particular parasite. It is also used as a gametocidal drug in Plasmodium falciparum infections to prevent transmission. Okay? When it comes to the Plasmodium falciparum, it's basically to prevent transmission, because here it is going to be working in conjunction with other effective blood schizontocidal drugs by killing off the gametocytes. So when the mosquito comes for a blood meal, the gametocytes will not be available for uptake by the mosquito, and then the transmission will be broken. This drug is given orally. Common adverse effects include anorexia, nausea, vomiting, abdominal cramps, chest pain, weakness, anemia, bone marrow suppression.